Thank you. Yes, so we'll open it up to questions for the whole panel.
Thoughts. Is this better? One is reflecting on what Sean said about symptom-based scheduling. I see that a lot in the messages that come through and in what I'm seeing, and so I couldn't agree more that I think that's the future, and we really have to build around that. And I want to echo, combining what Sean said about that to what Jane just said. At the VA, we very much have a strong team structure. So we have our PACT, patient-aligned care team. The difference in the Atrius model, where you often have that APC paired with the PCP, is that at VA, we have an RN care manager. So the scope of the symptom that could be assigned to a visit with the RN is different. So it would have to be low acuity in a lower complexity patient. However, a smart scheduling system, and maybe even this requires a human to come in and contribute to that, would be able to say, I have super complicated patients who prefer to come in or maybe just need to come in, but they really have a shoulder issue that will take about a minute for me to assess, and I can be in and out with the nurse very quickly. And so that can be a really, really great use of my time. So a scheduling system for VA to really optimize the PCMHI that we talked about yesterday, integrated mental health. So when a patient is calling about a symptom of anxiety, it's more appropriately seen by somebody who I am going to send them to anyway for triage and assessment, because so much of what we do is pretty complicated mental health and is sometimes seen by multiple layers of different kinds of mental health providers. The clinical pharmacist plays a huge role in disease management, so often doesn't need to go to me, maybe can roll straight to the clinical pharmacist, and the same with the RN care manager. The second point I want to make is about the airline scheduling that we talked a little bit more about yesterday. So if we take airline scheduling, and maybe it's too early in the morning to be talking about online dating programs, but it made me think about what Desiree said and what Jane followed up on is as far as those preferences. I see this a lot at VA. Veterans tend to have pretty strong preferences, I think, because of their history and their background. So, they will, like Desiree said, prefer a man, a woman. But what about, when you pick a flight, you can see what the ratings are of that flight. You can see how often that flight was delayed, how often it was on time. There's data behind that flight that will push me one way or another to choose it, right? And then there's actually all sorts of data about providers too. Not that I'm advertising, I put mine out there as far as how often I run late, how much virtual care I use by telehealth, how much secure messaging I do by My Healthy Vet, what my turnaround time on my messages are. That's tough, I think, for providers to be able to want to be willing to put that information out there publicly. But I think having that data and matching based on that data preliminarily when you're finding that match for the patient can maybe be data behind the scenes that can inform an initial match when you're talking about identifying that provider. So I think Atrius does a great job with profiling PCPs. Kaiser does the same. VA doesn't do such a great job. But I think that's something we can work on.
I hope what is a very simple question. I was just hoping that Kellyanne and Jane, you talked a lot about the importance of communication and getting all of the folks on board as you go through those transitions. But I didn't hear you mention anything about the patient experience in that and how you engaged patients as a part of that transition. And we heard yesterday from many folks about the importance of engaging veterans as we make these transitions to these systems. So I was hoping that you could speak a little bit about if or what you did during that transition to make it so smooth, because I do think that is a big part of the conversation we are having as we talk about this system transition, and if you had any tips or tricks as you went through that.
So I would say that one of the opportunities that we probably could have done better was to have voice of patient in our work groups. Primarily what we were doing to get the feedback was we were relying on the Press-Ganey reports as we went through, which we have seen improvement in those numbers, but we're also cautiously optimistic about those. We want to see a longer trend, which is why we also didn't want to reflect it, here today. So secretly, we know that we're moving in the right direction. And I would also say that we have been soliciting feedback from the local staff and leaders, specifically around the online scheduling, and looking for any comments or feedback that we have received from them. We don't have, outside of the hot comments in Press Ganey, which we've also been searching and looking for. So I think we could do better at trying to get the structure, but that's really where we've been at with this. And I do think that part of that was intentional in the sense that we were working on the foundational stuff, knowing that we were trying to hit their ease of scheduling appointments. So everything that we were doing was not, the only thing it did was provide more flexibility for them. We didn't change anything as far as their experience, other than they can see and access more thus far.
Just want to add one piece that reflects a little bit about some conversations about specialists, actually. And I've always found that patients look to their primary care provider to send them to the best person and to make sure that it's a coordination of care. And when that magic works, it's phenomenal. So one thing that we struggle with is, as being in Boston, there are a lot of specialists. And trying to coordinate with people both inside our walls and out is always a challenge. We have a lot of a great electronic exchange, which has helped a lot. But when you send a patient off to see a pulmonologist and you can't name them, the patient isn't so certain that that's the best pulmonologist. And so as we think about cues and this is a patient preference, PCP preference. And I think the specialist, too, really wants to see a patient who said, oh, Dr. Fogg said, da-da-da-da-da. You know, even if you've never met each other except in an elevator once 5 years ago, the patient needs to know that you're in collaboration together. So in the scheduling system, that is hard because you're hunting for the best access for pulmonary, but I have to be able to say their name or they're not going to trust it. So I'm not saying we've cracked the code on that, but it's a really important piece of providing what we do best, which is relational care.
That is also a place that we're starting to see groups do a lot more work around their provider finder in terms of being able to pre-establish what networks the providers are available to, what the providers' quality ratings are, even what providers' health grades are, that type of thing, so that as whether it's the referral clerk, whether it's the scheduler, or whether it's the doctor, that they can see as they're recommending a provider that they first of all are the right type of specialist. They're not just an orthopod, but they specialize in this particular type of surgery or follow-up, and that secondly, that they're sending them to a good person.
I think just my last comment is to keep in mind both sides of it, that we are at risk for making someone popular, and then they will have a long delay, and eventually they'll get to the point where, oh, I have to wait 6 months to see so-and-so, well, I'll just see whoever. So that's kind of just two sides of the coin.
This is going to be a little complicated, and I'm not sure it's going to be helpful, but I was thinking about the 4 pillars of improvement as I listened to these talks, and they are epistemology, or how we learn, psychology of change, appreciation of a system, and variation. So Kellyanne and Jane did a great job, I think, in actually talking in detail about behavior change and psychology of change. And too often when I see rollouts of information systems, the clinicians are interviewed, and a lot of input comes in, and then there's no follow-up, no real appreciation of what they've contributed, and feedback loops. So that's really important. Then how we learn, or epistemology and improvement, we usually talk about rapid cycle change, and knowing when to move from a pilot study in which you learn a lot to scale up is really tricky. So the diabetes prevention program and nurse family partnerships, these are big ticket pilots that looked really good, and then they're rolled out nationally, and people forget to look to see whether they're actually working or need further adaptation and learning. So the bigger the company, in my experience, the less the real legitimate authentic testing and amending of the process. So that's just something to really be cautious of, is leaping from pilot to rollout without continual learning. Appreciating the system. We talk a lot about the system, so I won't touch on that. I do want to talk a little bit about variation, which in improvement, just means is the change over time attributable to what you did? And I've noticed this tendency, which is pretty widespread, before-after analyses are useless. I really don't care what it was in 1922 and what it was in 1925. I want to know what was happening over that time, and I want to see the data in a time-ordered fashion. So several of you have been guilty of that, and so I really don't know if the change that you describe is attributable to what you actually did. And I'm going to give a caution here. Making sure that what you're claiming is attributable, what you did, is really important. So I'm going to pick a little bit on Eva here. So she did what I often see at meetings such as this, where they're information scientists. There was some really fancy algorithms and so forth, and central line-associated bloodstream infections declined by, I think you said, 20%. Well, they're declining all over the country. And when I go to an improvement meeting, it's all, we use the model for improvement. If I go to a lean meeting, we use lean. If I go to a device maker, it's, we now have catheters that are hydrophobic, impregnated with antibiotics, flexible, antithrombogenic, and that's why it's gone down. And probably all that's true, but in that case, there's a good lesson. Simpler is better. It's really a simple bundle, and it's all about accountability and execution at the point of care. And as far as I can tell, there was a little role for information science there, as you could enter the data and show your improvement in an automated way. That's great. But fundamentally, it was about improvement at point of care with a bundle and accountability. So be careful about that. If you have a clinical pathway, you can have a really fancy algorithm with all these things that the decision support gives you along the way. But basically, if you have a clinical pathway, it's where do you have your checklist, where do you have your standing order set, and so forth. More than 20 years ago, I did a study with an infectious disease fellow with a standing order set on paper to reduce inappropriate antibiotic prescribing. And we virtually wiped out the inappropriate antibiotic prescribing through a simple paper order set. Now you can computerize that. That's great. But it's not a fancy algorithm where you got to, well, you get the point. Anyways, there's better. There are 4 components to improvement, and be really careful about attributing what happened to what you did as opposed to other advances in the field. People resent that, actually, if they're in the other field. Thanks.
Can I at least make a comment?
Yourself,
I am not going to defend myself. I think the bloodstream infection and also the SSI, it truly, we were able to pinpoint precisely what is being really attributed by the identifiers, like the indicators that we identified. Like, for example, identifying which are the patients that are at risk and when they actually get bloodstream and what is the chance that they will die from it. Those are extraordinarily important, and the doctors really appreciate being able to pinpoint those, and that really comes out from the algorithms because it's too complex. And the surgical site infection, luckily we have everything documented, so it is very good. And I'm also very fortunate is because the doctors are the one that document everything, so they know exactly what are the things that they actually follow, and that is the clinical practice guideline that they've changed, and that they actually see the results. But you are absolutely right, and I think we must understand the data is going to give you, like, I think, the altruist is wonderful. You say about data analytics. It's absolutely, there's a lot of information from the data, but we also understand that technology as well as the clinical practice guidelines also improve, and equipment improved also. So I think that's important to know. But just as the airlines, right, if there are things that if you change, you really do see the difference. And those are the ones that you do like to be able to spread it so that all the other sites could be adopting.
And I don't want to get in debate, but actually I don't care at all about the risk of death from a CLABSI in a given patient. We should have next to no CLABSIs, and I don't care if the patient's really sick or not really sick. And so that doesn't help me. And frankly, I don't know, the doctors may love it, but basically nobody should get a CLABSI. And in the surgical site infection, there was a little window of time when a simple IT application in the OR that told you that, hey, you didn't give it within the hour or 30 minutes, so you better give it. That was helpful. Now it's part of the surgical safety checklist, it's a ceiling measure, everybody's doing it, and so we don't need IT anymore. So just being clear about where it's going to help us and where it's not really going to be helpful, and being humble about what we can do with IT, I think is really important.
So, Mike Davies, VA. I had the opportunity to be involved in that Columbus project, and it was fabulous. I was really excited about the machine learning. I think Rachel's presentation about the basics is critical. We got to marry that with the front line and all the rollout experience you did, so I just loved every one of these presentations. But I want to tell you where my head is in terms of some of the things that we struggle with every day in the VA when it comes to features of scheduling that I think we need to figure out and learn. When I don't know the answers to these things, maybe you guys do. And as you were talking, I was wondering about practical questions like, how far do we open the schedule? Right? When we went to DOD, they opened the schedule for 6 months. We said, great, we're going to take our 390-day rule and we're going to roll it back to your 6 month because we're opening it up too far. And they were saying, oh, we decided to open ours up 390 days because we don't know how long it should be, and if that's what you're doing, we're going to do it that way. So who knows what the right answer? This is a basic question around scheduling we need to know the answer to. When do you make the appointment? A simple question. Do you make it now when the patient goes out of the exam room? 95% of our 58 million appointments are return visits, and they're mostly face-to-face right now. They need to be virtual in the future. I get all that. We need to educate patients about when to do face-to-face and when to not. I get all that. At the same time, the reality we're living is some people blow by the checkout and don't make the appointment. How do we recover that? Some people stop and make the appointment, but if it's an appointment for near in the future, they're more likely to show. If it's a long ways in the future, they're not likely to show. How do we identify those people and remind them and get them to cancel and reschedule those? Because we know if a young male makes an appointment more than 6 months in advance, there's a 70% chance they'll no-show rate. Okay? We know that. We got to figure out how to incorporate that into our scheduling. Also, should the patient make it or should we make it? If it's a complex visit, we need features of the scheduling system that allow us to say, this is one we should make, right? Because it's not something you can do online. Also, I think a key feature of the scheduling system is to figure out how do we make good appointments. We have not in the VA had good scripts or good ways to say to the scheduler under these circumstances, say these things, right? Or prepare the patient for the next visit in this way. Or what information should we give to the patient so that they know how to cancel and reschedule easily, or who they can bring to the appointment. I mean, all that stuff has to be thought about when it comes to making good appointments. And I think from my struggles in trying to do this in VA for the last 10 or 15 years, that is much harder to do than, it seems like. And I think we're talking about great things in the future. We got to keep those basics, things in mind. How does the scheduler manage those queues that are now building up in the scheduling system? We have the schedule in the future, standby queues for schedule today, requests that are there that don't have an appointment associated with them. Should we make those queue appointments today or should we make them in the future? We have this recall reminder system where we make some appointments just in time for those appointments a year out. Is that the best way to do it or should they be made today? We've got now undersecretaries for health dictating when we should make appointments. I think we need data and help to discover what the best way to do that is instead of making it a political, sort of call and decision in the way our system is working. When do we reach out for those cancels and reschedule? When do we alert patients? Which patients do we alert and which ones don't we? All that stuff is stuff we're struggling with. FastPass, fabulous. And I think we're trying to do that, to offer those patients the sooner appointment and get them in. And I think that's got to be a basic feature of any future scheduling system in my mind. That's a big deal. And finally, I think all the stuff you guys talked about in Atrius for the rollout, love to connect, a little bit more to get some of those lessons learned, because I think we learned a lot of the same things in Columbus, and, we need to memorialize that for people who do this sort of thing. I mean, this idea of sitting down with the providers and talking about their grids, so important. I mean, so important. So just wanted to contribute those comments for the record and for the things that we need to try and solve in the sooner rather than later. Thanks.
I want a first response, or I'm sure we all had like 10 responses. I try to keep mine a little more high level. I've always been shocked at systems that don't have a schedule available to the typical need of the patient. And my own pediatrician used to do that. It used to drive me bananas because he sees my kids once a year and he's got a 3-month template. And I don't go home and put on my calendar in 9 months, call the pediatrician. So I do believe that there's it's got to be at least a year, and I've always practiced in environments that were 2 years, but I'm not pretending that that's data driven. That's more been the habit I've had. I think you need to know your patient, and I fully agree that a healthy young person might need a tickler pushed out at them, an email that's going to pop up, a text that's going to come out in 11 months to get that follow-up appointment, whereas my 55-year-old with rheumatoid arthritis and diabetes, I do not want her to go out the door without the appropriate steps. And I don't have many patients that go home and say, I'm going to pick up the phone and get my mammogram bone density, get the rheumatology appointment, book my labs. Like, I've not had that many who do that. So I think if you know your patient, there's 2 pathways. Do you want the tickler? We need to sit down and have a little more hand-holding, make sure the next steps are solid. And at Atrius in primary care, we'd very much like to have our specialty appointments booked on the way out the door, our major imaging tests. It's a struggle with prior authorizations and all those steps, but we believe that that's more patient-centric for the right patient. I think the other aspect, just at a high level, that's my dream. As I've watched how EHRs have really changed the practice of primary care in particular, and the amount of time that we spend documenting, what I'm seeing, and I started on a paper record, way back in a community health center, what I'm seeing over time is that because we're spending time incorporating data, we're not actually putting down the data that helps our team or our patient know where to go next. In my perfect world, there would be more data either entered by patient or entered by team. Things like medication lists and problem lists would not require me, the physician, to do 100% of the cleanup. But what you do want me to do is to set the stage for the next pieces. What is the actual care plan? The health modifiers that are harder to put into an algorithm, like pap smears, have a lot of different ways they can go. I want my docs to focus on that, but I can't get them there until they can give up the lengthy amount of data abstraction and documentation that they do today. So that's just my personal dream.
It's very interesting. I think I understand that Sean was saying the EMR is not designed for billing and stuff, but I think at least from our point of view, exactly, I really echo what you mentioned, is that the EMR truly push all the responsibility on the physician. And we truly see that physician actually reduce the time to see patients because they are the one that type everything in. And that's truly is unfortunate, I think. But one of the things that I think may be able to address your question is that you could see really patterns on how patients, what type of disease that they have, and what are the patterns of different individuals, how often they have to come in. So I like your analogy about the 180 days versus the 390, because when I was in Netherlands, I gave a talk on healthcare in the United States, and they said if we have any problem, we go to the United States. I said, this is interesting, because the lawn is always greener on the other end. So my feeling is that it is not one size fits all. I think it's going to be heterogeneous, and that's how you subtype patients. Even among the same type of disease, they will be different. And I think that's the beauty when the data is going to inform you, and that you also could make the decision. So remember, the data is only provide you with a picture, and then your decision is going to give a better insight on what's going on.
Adrian, do you want to ask a question?
Yeah, so I just this is just an open question panel. I'll start out by putting a little context to this. So one of the things that about the VA healthcare system that we love so much is that we tend to have a lifelong relationship with the healthcare system. It's very data-driven, evidence-based. We can count on the quality of care they provide. So, for example, somebody was talking about mental health. In order for a VA clinician to even, sorry, I used clinician. I think somebody said make it. So for a provider to do evidence-based mental health, whether it's CPT or EBT, they go through a pretty lengthy training, right? So there's like 3 workshops, and then there's like 6+ months of reviewing or recording consultation with somebody expert in the field. I mean, we know that the likelihood of the clinician in a healthcare provider in a VA healthcare system is pretty top-notch. You know, there's quite a bit of variance, but the variance is small, and so we have this confidence in the VA. With the reformation of the VA system, relying more on the community, one of the things I worry about, not only as a patient, but as somebody who tries to represent our members who are very highly reliant on VA, is the quality of care in the private sector. We know that the variance is quite wide. And so as a patient, when I have to supplement my care at VA by going into the community, first thing I want to know is, I mean, I do this with our pediatrician. But when we're selecting a doctor for our child, we don't just say, oh, yeah. We talk to people.
Yeah.
We try and find whatever information we can, good, bad, or otherwise.
Yeah.
But it's not out there. And I hate to say this, VA isn't good at doing that either internally, although they have all the data to show it. Mm-hmm. Rachel, you mentioned you worry about a doctor being popular. What's wrong with that?
Yeah.
I mean,
Yeah.
you know, don't you want all boats to rise for your patients?
Yeah.
Sean, you mentioned earlier it's got to be important that the system recognize more about their patients. I just want to reframe what all of you have presented in terms of how patients see what you're doing. And my question is, what are you doing to grow what you've done or what you're trying to do, and using what you know or what you would like to know about your clients or your patients to improve what you do day to day?
Thank you. I think we're ready for a break.
Let me ask one last question, perhaps. Yesterday, Don Goldman talked about Kano and the 5 types of quality. You know, the must-haves, the nice-to-have, the who gives a shit. Who cares, and then importantly, the last category of the things that really aren't quality or that are negative. You've mentioned a number of things in the must-have category and the nice-to-have category, and you think you would like to have a category. I wonder if you would want to call out any of the things, and I say this being mindful of all the bells and whistles and features and functions and EMRs and how useless a lot of them are. I wonder if you would call out any of the things that you would say are the negative features or the negative requirements in a scheduling system.
What is the question? So many.
Or to be considered later.
I think like having the rules, like you guys talked about the rules, they're designed behind the scenes, they're useful, but you have to be really careful how you put them into place. Like if you had a session limit that all of a sudden made physicals, you have to wait 9 months for your physical because there's this limit. Like we need, I think, ways that we can monitor these features that we put in place to make sure they don't go too far. I mean, I think there's a purpose for every feature that's been designed. We just don't want it to go in the wrong direction of what we're trying to achieve for delay and continuity.
Yeah. So,
I think it's more generic, but as we think about informatics systems, augmenting what people are doing, and we're so committed to efficiencies, you're trying to get all those algorithms behind the scenes. It is still an interface, right, between a human and a computer. And what we see a lot of time, we talk about EI heterogenesis, right? Because the thing tells you X, like you're saying, because I'm so busy, I'm sure smart people worked on this, I'm just going to do X. But that may be the wrong for that particular moment, and the ability, right, of the person working with the information to understand and contextualize what's about to happen next, that's a risk that exists. And I think particularly today we worry about that for our doctors, but also our schedulers, to say they're burnt out, they're working really hard. And if this brilliant thing that Epic or Cerner or Jane has come up with says do X, they may not think twice and just run down that pathway. And I think that starts to surface things, to your point around surveillance and making sure that you're thinking about those and picking that up. We see it quite a bit.
I'd like to say, having the experience of configuring both the Epic product for Columbus and now in the middle of configuring the Cerner product, one thing I've noticed is that software companies will create whatever customers ask for.
yes.
Right?
Yes.
Sometimes we ask for things that are incredibly unhelpful. And if we would put those things in place, we would be a disaster, right? I think DoD experienced that, frankly, when they put up Cerner the first time. I mean, the number of appointment types that they were able to see took them down for a while, right?
Yes.
So I think the magic of that's a great question. I think the magic of that, in my experience, is the team that's doing the configuration has to really be wise and experienced and a little bit smart, about what to do. I also think that the software companies who have this worldwide experience should be doing some mining of the questions that we've kicked around in this seminar, for example. And you guys know, hidden in your data back there somewhere, what the best answers to some of these things are. And there should be an idealized sort of recommended rollout configuration of this stuff that I think is probably stronger than exists now. I mean, the companies are very interested in pleasing the customer, but, they also know what's right.
I would just want to add that, echoing what Joe said, this is marrying data technology with humans, and you can never take the human out of this. And we've found that we need to strengthen our pods at Atrius, primarily because the problem solving that comes up around simple things like scheduling, what are they coming in for, what's going on, can't necessarily be solved by data. It may not hold the elements you need. It may not be in the right place at the right time. And some things are just arguably not possible. And I think the value, I once answered phones for Harvard Community Health Plan, made me want to become a doctor and not do scheduling. So it worked. But I remember it was a relationship that I had with the physicians that I was supporting and the patients I was supporting. And if we didn't talk, there's no amount of data logic or system setup that would have let me do the best job I could do by the patient and the physician. So
Rachel, I'm mindful of the time, and so I think maybe we should take a break and reconvene in maybe a little less than 15 minutes. And so, John? Okay. All right. So we'll take 15 minutes then.